What's up? This is Dr. Torrance. I am live here at the St. Pete office, and I'm excited to be joined by Dr. Zakas. I'm trying to see where he's at. What I want you to do is pop in some questions down below, whether it's image-guided interventional injection related, whether it's just doctor questions, fitness, that kind of stuff. We're happy to answer those today. And I'm trying this new streaming service, so I'm going to see how this goes. And we will go from there. Let's see, is he having any issues? I got my tech team. I'm working with Dr. Zakas. He's up in the Winter Park office. So if you don't like or follow us at this point, make sure you like or follow us. I'm going to be talking to him. Hey, there he is. I'm going to add him to the stage. We are bringing it. Dr. Zakas, there you are. Can you hear me?
Dr. Torrance, how are you?
Yes, this is great. Look at this. This is working.
It is.
All right. This is the Regen Cell Doc. If you don't follow him, give him a like or follow. I'm super pumped to have him on here today. So
Dr. Torrance, I just need 1 second, my friend. Okay, my person here is knocking on the door. Give me 1 second.
Sounds good. Go dispose of that person. Are we good, Tanner?
Live on YouTube.
All right, live on Neurogen YouTube. Got it. All right. We're just doing fact checking. We will. Am I live on?
All right, I'm good. Sorry about that.
All right. So let's dive in. So one of the biggest things that I get asked, and let's see, what was the case today that I'm looking at a spine right now. Dr. Zakas, can you work with patients who have sciatica?
Yes, of course, absolutely. So sciatica, what patients are told is sciatica, or what they believe might be sciatica, is usually caused by multiple different things. It could be caused by pinched nerves in the low back. It could be caused by the sacroiliac joint, which is kind of mimicking that pain down the leg. It could be caused by a nerve getting irritated in the piriformis if it goes through the piriformis. So pain down the leg can have multiple causes, but almost all of those causes are things that we can address.
Awesome. And I'm showing some anatomy here, anatomy of the lumbar spine, some vertebral bodies, disc issues. Just saw a patient with a big flare up, younger kid, having some ridiculous symptoms, and really want to just give him some options that are non-surgical to get him better. So definitely just like sciatica, I don't think people realize that that's coming from the back mostly. And this is how that happens with these discs, facet cysts, those types of things can really kind of lead to that. So just want to make sure that everybody is aware and savvy on that. So sciatica usually is coming from the lower back. It's also called radicular symptoms in the business and those types of things. So what question or what thing did you get asked today that you would really, really like to address? I mean, I like this for us, just kind of like throw out things that I hear all the time. I've got my med student here. Maybe I'll have him ask us a question here shortly to tell us what is something that we hear and see and discuss, and I want to make sure that we're addressing those things.
Sure. So one question that I get frequently from patients is they ask me if they have like a big disc herniation. Usually they're on the younger side. They have a disc herniation, and they're asking me whether or not the material from the disc can go back in. Usually they've had like a chiropractor or somebody trying to sell them on like a decompression table, tell them that, like if you do this decompression, then the material that's come out of the disc is going to go back into it. And so I get that all the time. And the truth is, the answer is no. There's no evidence at all that nuclear material from the inner part of the disc that's extruded out of the disc is going to go back in. But the good news is that it doesn't have to. So naturally, the body will start to heal that once that happens. And that can take many, many months or up to a year in some cases. And typically, if that material is not gone from the MRI within a year, then that disc is going to stay herniated. It becomes chronic. And then that's where we can come in. Of course, you don't have to wait a year, but a lot of times our patients have tried a lot of other conservative therapies and haven't gotten better. So we do have, we can't guarantee anything, of course, but we do have some MRI evidence that after our treatments for the low back with platelets and platelet lysate, that we can get some of these older disc herniations, which have not resolved on their own, to actually resolve. But it's not because the material is going back into the disc. It's because either the innate immune system or the immune system that we're giving a kickstart to through our procedures are actually going and cleaning up the mess and causing resolution, like the picture that you see there.
These are some actual MRI images. And as you can see, this looks more like a protrusion. And this looks like a right-sided protrusion. And I can't tell whether it kind of cut off some things. I'm assuming it's probably L3, it looks like, L3, 4.
Yeah.
So you can see that this one on a follow-up image looked a lot better. And again, Dr. Zakas said it very, very well. We're facilitating the body's own innate healing ability to get the disc to resolve itself. So this is more of a degenerative type disc. As you can see here, sometimes they get very, very inflamed and angry. And so angry is the white, a lot of inflammation on a T2 image. Wicked and water are white. So a little mnemonic that rings out from Fellowship for me. So you don't want to see wicked or water, which is white, on a T2 image. So that's what you're seeing here, a lot of white, and this is kind of a little bit less over on this side. So, and then I like to show a couple of studies that we look at for PRP. We use a lot of PRP for our back issues, platelet-rich plasma. And I'm with Dr. Zakas is an interventional spine fellowship trained clinician. So he's fantastic with spines, and super, super grateful to, work with him and learn a few knickknacks along the way. So, this is a study by Mary Ambach et al. And talking about a multi-targeted approach. That's what we do when we have spine issues. And we typically start with PRP, platelet-rich plasma. So that's something here. And these are kind of 90% of patients said that they were satisfied to very satisfied after the procedures. So we also have data. And this is what we can do and can't do. A really disc morphology improvement, less pain, more function. And we don't see we can't see disc height changes, and it doesn't work for everybody. So we want to make sure that everybody's aware of that. And this is a really good image here with the resolution, July 2018. This is a Dr. Lieber patient, and you can see how it got much better after 2 procedures. So that would be like my kind of addition to that. So let's talk about like cervical issues, Dr. Zakas. What's one thing that from cervical stuff that I would say what's one symptom that patients get that they might not think it's coming from their neck?
Yeah, that's great. So there's quite a few things. So, and it kind of depends on the area of the neck. So starting with the upper cervical spine, particularly the C1-2, C2-3 area, patients can get headaches. Typically from the C1-2, the headache can come over and sometimes even into their forehead or eye. From C2-3, you can get some above the head as well, but it tends to kind of stay in the back. And so that's something that is not going to really be able to be diagnosed just based on an MRI. That's something where we do have to actually do a hands-on exam of the patient, see if we can palpate those facet joints and get the pain to be recreated. Patients can also have symptoms such as dizziness from the upper cervical spine as well. A lot of times you see this after whiplash injuries. People's proprioception of where their kind of head is, its space is altered by the damage to the facet joints that kind of gives that feedback. And so they have a dizziness that's not like a room spinning, like a neurologic or like a vertigo, but they have a sense that they're off balance or that things are shifting underneath them. That's a type of dizziness that people get from upper cervical injury. As far as the lower neck goes, people there can have, the classic sort of sciatica, if you will, of the neck, or radicular pain typically goes down the arm. But also patients can just have upper thoracic pain as well as scapular pain. And they'll think the problem sometimes is coming from their upper thoracic spine. And people can have issues in the upper thoracic spine, but it's much less common. Typically, it's the C5, 6, and 7 that will refer pain down into the shoulder blade region. and the upper thoracic spine, or the upper part of the middle back, and even into the ribs sometimes. So sometimes patients come in and, they might have had an MRI of the thoracic spine, which is completely normal. And I examine them and I see, their actually lower cervical spine is tender, and order an MRI of their cervical spine, and they can have facet or disc or nerve issues in the lower cervical spine. And that usually clearly explains why they're having the pain that they're having. Oh, I think Dr. Torrance is frozen a little bit here. Fortunately, he's frozen pointing at the cervical spine. I think he's pointing at C5, C6 or C7 there. Also in the cervical spine, we should say that we see a lot of whiplash patients. And so I'll just take a minute to talk about what whiplash is. Whiplash typically happens when the head is sort of forced back and forth and whipped quickly. And you can see Dr. Torrance doing the motion there. And at the deeper level, this can cause problems to the discs, because this causes a lot of stress on them. But sometimes you'll see patients come in with very mild changes on their MRI. And it's typically because the ligaments and the tendons of the neck, of the cervical spine, have become damaged. And if those don't heal well within 2 to 3 months, typically the body and the immune system stops trying to heal them, and people end up with chronic pain. And so the procedures that we do, typically starting with platelet-rich plasma, are like kick-starting the body to heal these areas again. And we have to inject into the facet joints, the facet capsules, which are the ligamentous tissue that holds up those facet joints together, as well as the ligaments in between the spinous processes of the cervical spine, the interspinous ligaments and the supraspinous ligaments on top of them. And then we also do some of the muscle attachments, typically at the base of the skull and other areas as we need to. But whiplash is a pretty serious condition. People, really can feel hopeless with this, because a lot of times they've tried physical therapy and they've tried chiropractic and medications, and maybe they even had a steroid injection. And if you go to a conventional pain doctor, they're going to offer them radiofrequency ablations, which will take the sensation away from those injured facet joints, but does nothing to actually attempt to heal the problem. It doesn't heal the ligaments and heal the facet joints. It just takes away the nerve sensation to them. And at best, that gives them maybe 6 to 12 months worth of relief. But then they have to keep repeating that procedure over and over and over again. And that's accompanied by weakening of the muscles in the neck every time they do that. So radiofrequency ablation truly is a pain management technique, and that it is something that has to be done repeatedly to manage the pain, versus if you catch somebody early enough and there's not a lot of structural damage to the spine, we can get some regeneration of the ligaments in the neck, which can actually reverse the damage that was caused by the injury.
Awesome. Great description. I got cut off. I think I was getting a little technical difficulties. So I just brought out my spine here to show you some things. This is your cervical spine. We are missing C1. So we have C2, which is the axis. And these are some of the areas that Dr. Zakas was talking about: C2, C3, C4, C5. And again, those can radiate down to the mid-back, and those facets can cause wreak some havoc. The instability up there, you mentioned a DMX flexion extension X-ray. Did you mention that at all?
I haven't mentioned that, but yeah, that's a really good thing to, not all patients really need that. So typically on, a DMX report, they include a lot of things that we kind of already know just based on our exam, like, maybe there's some excess movement, typically lower in the mid-neck. So DMXs are most important when we're diagnosing issues with the upper cervical spine, say from C2, 3 and above. And so some patients do need that. And sometimes that's kind of like a diagnosis of exclusion. If people aren't getting better with what we would expect, then we order the DMX. Or if they're having symptoms that we can't quite relate to their neck pain, then we can order a DMX. But for most people, I can't give a number. I'd say most patients typically don't need a DMX unless at the initial appointment we're suspicious for some pathology that's up high in the neck.
Yeah, I concur. I think that's a fantastic statement. And if you're having certain symptoms that might be related to upper cervical issues, please let us know. We are trained in doing a lot of those injections, especially with C1, C2. Dr. Centeno is really the foremost in the PICL procedure, which we shall be working on and working with shortly. So what else? Tanner, what do you got for me? What's off the cuff question?
Yeah, absolutely. So I hear you talk about your different tools in your toolbox.
Yeah.
Could you just quickly explain to me what you like to use those different tools for?
Sure. So the tools in the toolbox. Thank you, Tanner, medical student, a fantastic medical student who's been working with us. So we've got different tools in the toolbox. And so I like to tell patients a lot of times, if it's a mild to moderate issue, whether it's a arthritis, whether that's mild to moderate tendon issue, tendonitis, tendinosis, small partial tears, that's usually going to be a platelet-rich plasma procedure that we would recommend. They should all be image guided. So if you're not coming to see us for a consultation and you're seeing somebody else, if they're not using an ultrasound or live x-ray, image guidance is crucial. And it's going to be the reason that your PRP didn't work if it doesn't work. Number one. Number two, you also need to make sure that the PRP is highly concentrated and making sure that you have somebody who takes enough blood to get a high concentration to get the right outcome. If you're taking 2 tubes of blood or 1 tube of blood, it's probably not platelet-rich plasma. It's probably just platelets, the platelets that you get in your blood, your normal blood. So if somebody's not taking 20 tubes or above, if they're 8 cc tubes, sometimes they have bigger tubes. So if somebody's got a 60 cc tube or something along those lines, I can see them taking like 3 tubes and that being insufficient. But usually a tube blood draw is a big difference. Now, the other tools in our toolbox, we do bone marrow concentrate procedures, and people get scared by this, but bone marrow concentrate is where you get your body's live stem cells from. And that is the best source to do it from, as they're live cells. They're not coming from baby tissue. They're coming from your tissue. They don't have rejection capabilities. And those we usually do best for whether it's moderate to severe arthritis or moderate to severe larger tears, partial thickness, full thickness tears. That's usually what we use that tool in the toolbox for. And then we'll use MFAT or micronized fat along the way to kind of be a scaffold. So those are kind of the 3 major players in the toolbox, coupled with image guidance, really makes each of the clinicians here on this call much, much different than Joe Schmo down the street doing PRP.
Mm-hmm. Absolutely. And one of the questions I get often, Dr. Torrance, too, from patients is, what about prolotherapy? Mm-hmm. And sometimes patients have come in already having done prolotherapy, or they saw another doctor in town or in the state who's recommended prolotherapy. And I'm a little bit older than you, Dr. Torrance. I was around when I went to medical school, all there was prolotherapy. There was none of the other tools that we have now. And that's what I thought my career was going to be, because that's all there was back then. But in general, it's important for patients to understand is that when a doctor is doing prolotherapy, even if it's with image guidance, prolotherapy, first of all, prolotherapy is typically an injection of a dextrose-based solution that causes a small localized reaction in the ligament or a tendon to institute healing. Okay, so that's what it is. So prolotherapy only treats the ligaments and the tendons. So when you're talking about the spine, there's a lot of other things in there that can be causing your pain. So prolotherapy, again, just into the ligaments or tendons. It does not treat discs. It does not treat nerves, and they're typically not actually getting into the facet joints themselves. Mm-hmm. They're doing a perifacet injection or a capsular injection, which is around the outside. Mm-hmm. And that can give people relief if their issue is only ligament or tendon. That can give relief. So prolotherapy is and was a pretty useful tool. The other thing about prolotherapy, though, is it takes a lot more sessions than a high concentration platelet-rich plasma does. So for most patients, the vast majority of patients, we got a comment there, so I was distracted. So for the vast majority of patients, PRP is going to get a job done much faster. So for our spine procedures, what we can accomplish typically in one spine procedure might take 4 or 5 prolotherapy treatments. So it's more efficient. It's also usually more cost effective. It's safer because you're having less needle pokes overall. And again, with our functional spinal unit model of treating the spine, we're not just treating ligaments and tendons. We're treating muscles with platelet-poor plasma. We're treating facet joints with platelet-rich plasma. And we're treating discs and nerves typically with platelet lysate to start. So prolotherapy really was kind of the grandfather of regenerative medicine and orthobiologics, but for the most part now, there are better, faster, more cost-effective options.
And I've heard prolotherapy described as the kind of grandfather of regenerative injections in general. And the way I look at it, and I heard it visualized in my head, is that prolotherapy, I look at it as a kind of a bow and arrow. you're using a bow and arrow to try to do this, but you need to do it multiple times. Okay.
Yeah.
That's the first kind of thing that you can use. PRP is more of like your pew pew, your little gun, your little handgun. It usually can get the job done for some things and some things that are not as severe. But then the bigger gun, which is the bone marrow concentrate, the MFAT, they kind of line that AR, that bigger gun. Sorry about the gun reference, but that's one of my favorite references. So if we want to talk about like fires, it's maybe rubbing the sticks together. We talk about rubbing sticks together for prolotherapy. If you get a lighter, that's more of the PRP. And then if you get a torch, that's really more of your big gun, right? So that'd be the bone marrow concentrate. I think that's probably the best analogy that I can use for that. I wanted to bring up another image here. When we talked about the facet referral pattern, we got that referral pattern, scapular pain. What a powerful procedure for this referral pattern. And thanks, Dr. Perrone. That's my wife, Abby Torrance. She's on here throwing some questions at us. But so what comes up? We talk about the referral pattern. Oh, our friends at the Centeno Schultz Clinic, Dr. Markle, Dr. Pitts, Dr. Centeno, Dr. Schultz, good friends and colleagues. And so this referral pattern is what we were talking about. Dr. Zakas was showing this. I show this to my patients all the time, and this is showing the cervical facet joint injections that we do to help with these kind of referral patterns. So this is just a really good, powerful thing to show, and I wanted to kind of bring this up. So awesome. And then we can hide her question. But yeah, so this is getting my legs underneath me for this new StreamYard. I'm hoping that this is helpful for our patients. We'll try to, Dr. Zakas, I will try to do this at least every other week. Anything else, Dr. Zakas, top of mind? I had a patient today as well. Similar patient with the lumbar spine issues, and also had a pars fracture. I had a case of a pars fracture with a softball player that I worked with that I was able to actually see a healing pattern. And I'll actually pull that up. Let me see here. Give me 1 second here. So tell them a little about pars fractures and what those are, Dr. Zakas, while I pull this slide up.
Sure. So pars fractures in general, there's two types of patients that end up with pars fractures, and one is more congenital and one can be more degenerative. So in this case, this was you said a softball player. So imagine this was probably a younger patient. Oh, very young, 15 years old. And so the pars interarticularis is a part of the posterior bony elements of the spine that helps kind of hold the middle column of the spine to the posterior, the back column of the spine. And so when people can have fractures of these that happen from stress kind of over time, and sometimes there might be a component where they might have sort of been there, or they might have been weaker, or there might have been like an isthmus of a bone there, or a weakened bone there to begin with, and then usually it's extension over and over again causes this break to happen and causes chronic inflammation and pain. So in a 15-year-old, when they come in with chronic back pain and they're athletic, this has to be high on our differential of what the cause could be.
And so this is the picture of the pars fracture. She actually had a congenital, left-sided congenital defect, but the symptomatic side was on this right side, and you can see it here. And so that was the initial CT scan. And then as you can see, that was later on, you can see this is the follow-up CT scan, and you can see the healing of that pars fracture. So this was 12 weeks post, and the patient was doing much, much better at 4 weeks. So always great to see some cool, and this was actually her playing in a softball game. I don't think we got a good image, but she was back playing and participating in softball. So great patient case that I thought of, and I was just going through some slides trying to get this ready for today. So cool experience. But yeah, these are some great cases. Dr. Zakas did my back recently. I think I'm a good case for lumbar spine, sitting intolerance. That's usually consistent with an annular tear. Do you want to describe an annular tear real quick, and we can kind of go from there?
Yeah. So not all disc injuries involve a herniation or a bulge, and that is some of the material kind of pooching out in the canal. So what an annular tear is a tear within the substance of the disc that's contained. So you may see it within a bulge, but you may not. And I can't remember exactly what your MRI looked like, but On a MRI, what we look for that is indicative of an annular tear is something called a high intensity zone, or an HIZ, which is represented as a small amount of white fluid on a certain sequence of the MRI in the back, which basically says, hey, this disc is inflamed. Now, on the inside of that disc, we don't always know exactly which way that's going. There's a few different ways that the annular material can kind of come out, but really only the outer third of the disc has innervation, meaning it has nerves there. So when somebody has a tear in the disc from the inside, if it doesn't penetrate to that outer half to outer third of the disc, they'll never know that it's even there. So typically what happens is the disc starts to wear over time, and the annular tear gets deeper and deeper out of the disc and into the periphery. And then usually once it hits that outer third, that's when the nerves sense it. It can cause extreme pain. And so like Dr. Torrance said, we will have sitting intolerance, but this is also what is affected when people have this experience of their back going out, meaning they either sit or stand or bend over to tie their shoe, they make a movement and they get stuck and they can't get off the floor, and they just have like severe pain. A lot of times people have to go to the ER, they have to have a family member carry them or bring them there, or sometimes even call an ambulance. And so this is a really severe condition. It's a debilitating condition. And worst of all, it typically affects people who are active and younger, and it can just absolutely change people's lives for the worse. And so we're looking here at this MRI, and you can see here where Dr. Torrance is pointing to the high intensity zone there at L4-5, up to the middle, maybe teases a bit to the right there.
Right here.
And, yeah, so you can see it on the sagittal and axial cuts there. And so what we don't know from looking at an MRI like this is that disc actually open a little bit and communicating with the epidural space, or is it closed? And that can be important for treatment. And this isn't something that's proven, but this is likely just a practice observation, is that typically when we start to treat these, we do epidural injections with platelet lysate. And I've had these done on my back as well, and actually responded very well. And my theory is that if there's a little bit of an opening in that disc, that allows some of the platelet lysate to get in there. Also, it can kind of just wash away some of the chemicals that are irritating the outer part of the disc as well as the nerves. And I think that's one of the reasons why these platelet lysate epidurals work so well. If that does not work well for someone, sometimes we do have to actually inject either high concentration platelet-rich plasma or bone marrow concentrate into the actual disc itself to get the disc from the inside. But not everybody needs that. That procedure is very safe, but it is a little bit more uncomfortable, and there are some small infection risks with that. So we don't always jump to that immediately. But again, from my experience, and Dr. Torrance, you can tell me yours, it seems like even with high intensity zones, like a lot of patients get a lot of relief from the platelet lysate epidurals as part of the whole DDD Regenx treatment.
When I see these, I've seen about 70 to 80% of patients get a pretty good response with just outside the disc injections or transforaminal epidurals. And so that's really what I tell patients. Let's start with more conservative approach. Don't go into the disc. And if you don't get the response that we're expecting to see, a 50 to 60% improvement in pain and function, then we would shift to the interdiscal approach. If you get more than a 50 to 60% improvement, let's see how it goes. Let's maybe re-image later down the road. If you're like, hey, I got 50 to 60%, but I want more, and we don't want to take that next step to go into the disc, we can go outside the disc again. And so really having a good relationship with your clinician and making sure that you communicate and you continue to follow up. That's really the key here, because for back issues, it's the number one, number two thing, depending on the year and what people are seeing in the ER and the hospital. And it's debilitating. And this is why there's different solutions, and this is a great solution for this type of issue. So I'm doing a lot better. Am I perfect? No, but I think that I've got a good team that I can work with. So,
I'd also like to add, Dr. Torrance, is for these annular tears, there is no good conservative treatment for this that works very well. Typically, these become episodic in people, and in a lot of patients, they go from throwing out their back maybe once or twice a year, and all of a sudden now it's 3 times a year. Then it's 4 times a year. And so there is no pain management interventional technique right now that actually treats these. There was something back when I was in my initial pain fellowship, there was something called IDET, where we were putting some probes into the disc and kind of denucleating them with heat. And that was something that was approved and it worked on some people, didn't work on others. And then Medicare cut reimbursement. So nobody's really doing that anymore. But Dr. Lutz's studies on high concentration PRP really were a game changer for this condition, especially intradiscal, because there's really nothing else that actually treats the cause of these annular tears and can actually get these to resolve for the long run. There's really nothing else. So patients typically will have some epidural steroid injections. Maybe they'll do RFAs, which weaken the muscle, but don't treat the cause, and then physical therapy. And other than that, they just kind of have to deal with it. And a lot of these patients are absolutely miserable with this condition.
Yeah, and Dr. Lutz, Heal Thy Disc is the book. Unfortunately, we lost him to almost like a year or two ago, and he was a pioneer at Hospital for Special Surgery, and he did a lot of injections with high concentrate PRP into the disc. And we're grateful for this approach and this ability to really bring this technique and technology to help patients get better. So this is what I'm hoping for. I'm hoping to not have to go on the disc, but if I have to, I know I got a great team to do it. Dr. Zakas did my injections, and grateful to have him as a skilled clinician with the Regenerative and Neurogeneration Orthopedics team. If you don't like, subscribe, follow. We are here. We are in Sarasota, Tampa, St. Pete, and Orlando full time now. So please make sure you reach out, schedule a consult. And I think that will be it for tonight, Dr. Zakas. You good with that?
All right. I'm good with that. Thanks so much, Dr. Torrance.
All right. Have a wonderful. Talk to you soon.
All right. Have a good night. Bye-bye.